Insulin is the body's bouncer at the club door of your cells. It decides who gets in, who stays out, and how crowded it gets inside. When that bouncer is overworked, distracted, and screaming orders all day long, chaos follows. That chaos is what we call chronic hyperinsulinemia, and it quietly drives a huge portion of the chronic disease I see in clinic. Let me start with my friend's comment, because he nailed it. He watches Dr. Boz on Diary of a CEO break down insulin. He thought, if this is so important, why has no one explained this to me? Why don't doctors talk about this? And he's right to ask. He studies optimization and high performance and can smell a key success factor a mile away. Insulin is exactly that. So in this video, I want to do 3 things. First, explain in plain English but with real mechanisms, why chronically high insulin is the root cause behind so many problems. Obesity, type 2 diabetes, fatty liver, PCOS, hypertension, dementia risk, you name it. Second, explain why most doctors don't talk about it, don't test it, and often don't even recognize it early. And third, give both patients and doctors a clear call to action so we can stop playing whack-a-mole with symptoms and finally fix the wiring. Let's start with the physiology. Insulin is a storage hormone. After you eat, especially carbs, glucose rises in your bloodstream. Your pancreas releases insulin, and insulin's job is to escort the glucose into cells, or if the storage is full, to shove it into fat cells for later. Short bursts of insulin are normal and healthy. The problem is not insulin itself. The problem is marinating in insulin all day, every day, for years. When insulin is always high, your cells start to become resistant. It's like someone shouting your name all day. You eventually tune it out. Shout out to all the parents out there. So now the pancreas has to shout louder. Insulin levels go even higher to push the same amount of sugar into the cells. Here's the interesting part. Blood sugar might still look okay on your labs for years, but under the surface, your insulin has been sky high working overtime. By the time the fasting glucose or A1C finally looks bad, the house has already been on fire for a decade. Now, why does this lead to so many diseases? Take obesity. Insulin is a fat storage hormone and a fat-locking hormone. When insulin is high, you are in storage mode, not burn mode. Your fat cells are instructed, take in energy and do not let it go. So people tell me, Doc, I'm eating less, but I'm always hungry and I'm not losing weight. If your insulin is elevated all the time, your fat is locked away. Your brain senses low available fuel, even though you're literally wearing your fuel around your waist. So you're hungry, tired, and blamed for lack of willpower when the issue is hormonal. Take hypertension. Chronically high insulin tells the kidneys to retain sodium and water. Blood volume goes up. Blood pressure follows. Insulin also stiffens your blood vessels and activates the sympathetic nervous system, the fight or flight tone. So we treat blood pressure with 3 drugs. But never ask, is this being driven by chronically high insulin and processed food that keeps spiking it? Take fatty liver. Excess carbs, especially sugars and refined starches, are converted in the liver into fat through de novo lipogenesis. Insulin is the conductor of that orchestra. Over time, the liver becomes stuffed with fat, leading to non-alcoholic fatty liver disease. Many of those patients don't drink much alcohol at all. They drink soda and fruit juice and live on ultra-processed carbs. Take PCOS in women. High insulin drives the ovaries to produce more androgens, worsens ovulation problems, and promote weight gain around the middle. We prescribe metformin and birth control, but lifestyle strategies to lower insulin can be game changers. I could keep going. Brain fog, dementia risk, gout flares, sleep apnea. When insulin is high, inflammation, oxidative stress, and fat storage all increase. This is why so many of us are now saying insulin, not just glucose, is the root problem in metabolic disease. So if this is central, here comes the obvious question. Why don't most doctors talk about insulin like this? Why don't they test fasting insulin, or at least talk about it with their patients? There are a few pretty honest reasons. First, training. Most physicians simply were not trained to think in terms of hyperinsulinemia. In medical school and residency, we learned to diagnose diabetes using fasting glucose and A1C, not insulin. We were taught that type 2 diabetes is about high blood sugar, and the solution is drugs that lower blood sugar. We didn't spend much time on the earliest stage, years of elevated insulin when glucose is still normal. So if the only tool you have is a glucometer, you don't look for the fire that started before the smoke. Second, the guidelines and quality metrics we're judged by are all built around blood sugar, blood pressure, and LDL, not fasting insulin. Nobody sends your doctor a nasty letter because they missed your hyperinsulinemia, but they do get measured and graded on whether your A1C is under 7, whether your LDL is under 100, whether you're on a statin. So the system quietly trains us. Control the downstream numbers and don't ask too many upstream questions. Third, test and time. Fasting insulin is not always ordered because it's not in the standard panel. Many clinicians are not comfortable interpreting it. Is 15 normal? Is 5 optimal? What about a 2-hour insulin after a glucose load? That's not how most clinics are set up. Interpreting insulin and then doing something about it requires nutritional counseling, behavioral change, and motivational interviewing. Try doing that in a 12-minute visit sandwiched between prior authorizations and refill requests. Fourth, culture. Nutrition has been historically underemphasized in medical training. Most doctors get a few lectures on vitamins and food groups and move on. So when someone like Dr. Boz or myself comes along saying, let's reverse insulin resistance with food, it sounds radical, even though it's just physiology plus steak and eggs instead of soda and cereal. Now, I want to be very clear. This is not a doctor bashing video. Most of my colleagues care deeply. They're drowning in a system that rewards quick fixes, not deep dives. They were simply never given the insulin lens, so they can't use it. So what do we do with this? If you're a patient, your call to action is this. Become insulin aware and respectfully curious. At your next visit, you might say, I've been learning about insulin resistance and hyperinsulinemia. Would it be reasonable to check a fasting insulin with my next labs? Or an oral glucose and insulin test if that's available? You're not attacking, you're inviting a conversation. Also pay attention to your insulin lifestyle. Ask yourself, how many times per day am I asking my pancreas to yell insulin? Every time you consume sugar, refined grains, juice, constant snacking, your insulin surges. Consider shifting toward meals centered on protein and healthy fats, fewer ultra-processed foods, and fewer eating occasions. Your cravings, energy, and weight will tell you you're on the right path long before your labs catch up. Advocate for yourself. If your waist is expanding, your triglycerides are climbing, your HDL is low, your blood pressure is creeping up, and everyone keeps saying your sugar is fine, you're normal. That's not fine. That's the insulin whisper getting louder. Those are signs of poor metabolic health. Ask someone to listen. If you're a clinician watching this, first, thank you for even clicking on a video about insulin. That already puts you in the top few percent. Here's your call to action. Before you add the next medication for blood pressure, blood sugar, or triglycerides, pause and ask, could this all be the same metabolic fire, better known as metabolic syndrome? Could hyperinsulinemia be the unifying thread? If your patient has central obesity, high triglycerides, low HDL, elevated blood pressure, and a fasting glucose that's borderline, you do not need a crystal ball to suspect insulin resistance or metabolic disease. Consider adding fasting insulin to your initial metabolic workup, or at least for high-risk patients. It's 1 tube of blood. Start simple. If fasting insulin is clearly elevated, that's a teaching moment. You don't have to be a low-carb zealot to say, your body is pumping out a lot of insulin. Let's work on reducing the foods and patterns that drive that. You're allowed to say, I don't know, but let's learn together. Our patients don't need us to be infallible. They need us to be curious, humble, and willing to address root causes, not just numbers on a dashboard. By the way, when you help someone lower their insulin and reverse metabolic disease through lifestyle, you don't just improve their labs. You often end up deprescribing blood pressure meds, diabetes meds, and yes, dare I say, statins. There are a few feelings better in medicine than taking people off medicine because their physiology has changed. So here's how I'd love to see this play out. Patience. Stop thinking of insulin as a diabetes hormone I don't have to care about unless I'm on shots. If you have a waistline, cravings, and afternoon crashes, or a family history of everyone gets diabetes and high blood pressure, insulin is your business now. Doctors and healthcare professionals, let's move insulin from the footnotes of our training to the front page of our practice. We've tried treating downstream numbers without addressing the upstream hormone. That's not working for us. So as we conclude, if this message resonates with you, share this video with one person, a friend who's struggling, or a clinician who's open-minded. And if you want more conversations like this, where we talk about metabolism, root causes, and what's actually working in real patients, stick around, because we're just getting started. I'll see you in the next video.